welcome to the deep dive. Today we're tackling something really common, but often a source of a lot of worry and discomfort: Bartholin gland cysts.
That's right.
And if you've ever dealt with this or treated it, our sources suggest that just understanding the basic setup down there really helps clear things up.
Absolutely. That's the goal today, isn't it? To kind of cut through the confusion, look at the evidence. We'll cover why they form, how we diagnose them, which interestingly changes based on symptoms.
Oh, okay.
Some really neat treatment options, and importantly, a critical warning related to patient age.
Good. Let's start with the basics then, the anatomy. What exactly are the Bartholin glands?
Okay, so picture two very small glands, maybe about the size of a pea.
Tiny.
Yeah, tiny. And they sit symmetrically, one on each side, just at the lower part of the vaginal opening.
And what do they do?
Simple vital function: lubrication. They produce the fluid that keeps the vulva and vagina moist. Normally, you wouldn't even know they're there doing their job.
Okay, let's unpack this then. When things go wrong, you mentioned it's often like a blockage, a plumbing issue.
Exactly. That's the root cause in occlusion. The duct gets blocked.
Right.
So the process, it's basically 3 steps. First, something blocks the duct. Could be debris, inflammation, thick mucus.
Okay.
Second, because it's blocked, the fluid the gland keeps making can't drain out like it normally would.
Makes sense.
And third, that fluid just builds up behind the blockage. It accumulates, creates a little sac. That's your cyst. It's just fluid. Initially, no infection.
So, quiet buildup at first. Maybe you don't even notice it. But these things have a reputation for being really, really painful.
They certainly can be.
So that must be the next step, right?
Yeah.
How does it go from just a fluid sac to something causing agony?
Yeah, that's the critical jump. It's infection. When bacteria get into that trapped fluid, things change fast.
Ah,
The sources mention typical culprits like chlamydia, staph bacteria, or often anaerobic bacteria, the ones that don't need oxygen. Once those bacteria set up shop in the cyst, it stops being just fluid and becomes pus. That's when you get an abscess, inflamed, painful, under pressure.
that sounds like a huge difference. When someone comes in with that kind of pain, do doctors try to figure out the exact bacteria? Or is it more like, let's just treat it quickly?
That's a great question. Usually with an acute abscess, it's red, swollen, incredibly tender. The priority is immediate relief and getting ahead of the infection.
Right, the pain.
Exactly. So treatment often starts empirically. That means using broad-spectrum antibiotics that cover the most likely bacteria, especially those anaerobes, while maybe taking a culture during drainage. But you don't wait for the results. The pain dictates you act fast.
Okay, that makes sense. That urgency, that pain level really drives the diagnosis then, separating it from just finding a quiet cyst.
Completely. It's 2 different clinical pictures. Most simple Bartholin cysts are actually asymptomatic. Someone might not even know they have one.
Found by accident.
Yeah, often found incidentally, during a routine pelvic exam. The provider feels a little lump, a protrusion on one side, lower vulva. It's usually movable, maybe feels a bit fluid-filled, but crucially, it's not tender.
Okay, just to there. Now contrast that with the abscess presentation.
Oh, it's night and day. With an abscess, you still see the protrusion, but now it's red, maybe warm to the touch, sometimes even draining a bit. And when examined, it's incredibly tender. Often feels much firmer, tense because of the pus inside under pressure. The patient usually describes intense, maybe throbbing pain.
And the sources mention something specific, that the pain often gets way worse during intercourse.
Yes, that's a classic sign. Any pressure or friction on that inflamed area intercourse, sometimes even sitting for a long time or cycling, can make the pain spike.
So if you hear that history, sudden one-sided vulvar pain, worse with activity and abscess is definitely top of mind.
High on the list, absolutely.
Let's backtrack slightly to the cause. You said the duct gets blocked. Why? Is it always clear, or sometimes it just happens?
Sometimes it's idiopathic, meaning we don't find a specific cause, but there are definite risk factors, things that can disrupt that little duct.
Like what?
Well, direct trauma to the area is one. Childbirth complications like an episiotomy or significant tears can play a role.
Okay.
And interestingly, sometimes just friction from intercourse itself can be enough to irritate or block the duct opening. Perineal surgery is another factor.
Wait, how does something like friction or maybe an old episiotomy scar cause a blockage later on? Is it scar tissue?
That's often the mechanism, yes. Healing involves scar tissue. If that scar tissue forms right around the duct opening or contracts as it matures, it can kind of pinch the duct closed or narrow it.
I see.
It disrupts the normal drainage pathway. It's all about keeping that duct pattern, keeping it open.
Okay, so we have the quiet cyst and the painful abscess. How does treatment differ? You mentioned it depends on symptoms.
Entirely on symptoms. If it's an asymptomatic cyst, just found on exam, maybe small, not bothering the patient, often the approach is just watch and wait.
Do nothing.
Or very conservative things. Warm compresses, sitz baths, soaking in warm water. The idea is the warmth might encourage it to drain on its own or just soothe the area.
But if it is symptomatic or definitely an abscess?
Then you need to intervene. You need to deal with the infection, usually with antibiotics, and you absolutely need to drain the pus.
Drainage. How is that typically done?
Well, simple incision and drainage works for immediate relief. You make a small cut, let the pus out. But the issue there is recurrence. It might just close up and fill again.
Ah.
And that's where this clever little device comes in the word catheter.
The word catheter. Yes, I remember reading about this. It sounds almost too simple.
It is elegantly simple, but really effective. It's often considered the standard for preventing recurrence.
So what does it do differently?
Okay, so after making the incision and draining the abscess, instead of just leaving it, the provider inserts this tiny catheter. It has a little balloon on the tip.
Right.
The balloon is inflated inside the empty cavity, just enough to keep the catheter in place. And the key part is it stays there.
For how long?
Often for several weeks. Maybe 2 to 4 weeks, sometimes longer.
Weeks. Wow, way so long.
Because that's the magic part. Keeping it open that long allows the body to heal around the catheter tract. The skin cells, the epithelium, grow along the path created by the catheter.
So it's like lining the tunnel.
Exactly. It creates a new, permanent, epithelialized drainage pathway. It's a process called marsupialization, essentially creating a permanent opening or pouch.
A new exit route for the gland's fluid.
Precisely. So when the catheter is finally removed, you have this new, stable duct that bypasses the original blockage. It drastically reduces the chance of it happening again.
And this could be done in an office.
Often, yes. It's typically an office procedure. Minimally invasive, really effective at solving the underlying plumbing problem long-term. Quite an innovation compared to more involved surgery.
It's fascinating. Okay, we've got the mechanism, diagnosis, treatment. Now let's talk about that critical warning you mentioned, the context change.
Yes, this is really important. It's about paying attention to who is presenting with the problem, specifically postmenopausal women.
Okay, why the focus on postmenopausal women?
Because the significance of a lump or swelling in that area changes dramatically after menopause. While in younger premenopausal women, these cysts and abscesses are overwhelmingly common and benign.
Right.
In a postmenopausal woman, a new growth in the Bartholin gland area raises a red flag for something more serious. Malignancy. Bartholin gland carcinoma.
Ah, cancer. That's rare though, isn't it?
It is rare overall, but it's something that must be considered in this age group. The hormonal environment is different, the glands are typically less active, so a new persistent mass is suspicious.
So if a provider sees something that looks like a Bartholin cyst in a postmenopausal patient, they shouldn't just assume it's benign.
Absolutely not. The index of suspicion has to be much higher. They need to look closely. Is it fixed? Is it unusually firm or hard rather than fluid-filled? Does it lack the typical signs of acute inflammation you'd see in an abscess?
I see. Less likely to be that angry, red, painful thing.
It might be, but often these malignancies can present more subtly. Maybe just a firm lump. The key takeaway from the sources is any new Bartholin area mass in a postmenopausal woman requires further investigation. Usually that means a biopsy to rule out cancer.
That's a really stark reminder of how patient context, like age, totally changes the clinical picture.
It's fundamental. You can't interpret the finding without the context. Age becomes a primary diagnostic clue here.
Okay, let's try and summarize the key points for everyone listening. What should they really take away from this deep dive?
All right. First, remember the basics. Small glands, job is lubrication. Second, the problem starts simple. Blocked duct leads to a fluid cyst. Bacteria get in, then you get a painful abscess.
And that pain during intercourse is a big clue for the abscess.
Definitely. Third, treatment depends on symptoms. Sitz baths for simple cysts, but for abscesses you need drainage, maybe antibiotics, and that clever word catheter is great for preventing it from coming back by making a new duct.
And finally, the crucial context point.
Yes. A cyst or abscess in a younger person is usually straightforward. But a similar finding after menopause, that needs immediate, serious attention to rule out malignancy.
It really highlights the need for vigilance.
It does. And maybe a final thought to consider. It underlines how the same physical finding can have vastly different levels of clinical seriousness based entirely on the patient's biological context in this case, pre versus postmenopause. It's a powerful lesson in differential diagnosis.
Absolutely. Thank you. That was incredibly clear and informative. A great deep dive.